Hi, my name is Marsha Nelson, and today I'm going to be presenting about increasing prescriber screening for metabolic syndrome in psychiatric patients. This was a practice change project. And this is the DMP committee that helped with this practice project. The DMP chair, Dr. Petrov, the community person, Dr. Hardrick, and then Dr. Snell, the director of nursing practice in the program here at Maryville. This is just a quick biography of myself. I was a BSN student at St. Kate's. I then got my MBA at St. Kate's University in Minnesota. I got my MSN Psych NP at Maryville, and now I am a DMP student here at Maryville University. Metabolic syndrome is a significant health issue. Metabolic abnormalities consist of hypertension, obesity, insulin resistance, and dyslipidemia. In the United States, an estimated 1 in 3 adults are diagnosed with metabolic syndrome. 40% of those adults are over the age of 40. And most individuals do not know that they have metabolic syndromes, as prescribers often don't screen for metabolic syndrome. The purpose and aim of the scholarly project are to increase the number of patients screened for metabolic syndrome and increase referrals for patients to the prevention care or primary care for follow-up care. This project aims and includes improved adherence to recommended guidelines and screening for metabolic syndrome, decrease long-term complications, increase the knowledge of metabolic syndrome for patients and prescribers, enhance the patient's quality of life, decrease adverse patient outcomes, and provide alerts to screen for metabolic syndrome in the electronic medical record. The question of this Doctor of Nursing Practice Change project answered the following question: will implementing practice alerts in the electronic medical record for psychiatric mental health prescribers improve the quality of life for patients when compared to the standard of care currently being provided? This project helped prescribers implement guidelines to monitor, diagnose, and treat metabolic syndrome to improve patient care. Furthermore, this project helped to guide the prescribers and leadership by implementing interventions to enhance patient care while preventing and detecting metabolic syndrome. A little background on the clinical site: there was little to no compliance of documentation for screening patients for metabolic syndrome. Ramsey County Mental Health Clinic serves a very underserved population who often do not have primary care providers in the community or have suffered from the stigma of mental illness. Many of our patients are unhoused and have food insecurities. The alert system was unable to notify providers when patients were due for metabolic screening. Therefore, the screenings did not take place. Patients prescribed atypical antipsychotics were not routinely screened for metabolic syndrome at the clinic. And studies have shown that screening for metabolic syndrome can identify patients at risk, and early treatment can decrease the negative impacts on health. Additionally, 23% of individuals taking atypical antipsychotic medications report hospitalizations in the past 12 months compared to 10% of the population. So it's very important to screen so we can do preventive care instead of having frequent hospitalizations that can impact the community in negative ways, including the high cost of care. So the theoretical framework used for this practice change project was Lippitt's model of change. It is adapted from the Lewin's change model. So it helps to identify the need of change by diagnosing change, establishing a relationship of change and assessing motivation and the ability for change, clarifying assessment and change and discovering resources, create goals and intent for an action plan, examine the possible course of action, modify intentions to the wanted change and sustain the change, and then generalize an inevitable change and end the relationship with the change agent. The method used for this practice change project was a quantitative exploratory retrospective chart review. It was conducted at the Ramsey County Mental Health Clinic, and I used the Adult Treatment Panel 3. So during the rooming process, the medical assistant or the nurse would have the patient go back into what we called the vital signs room. So at that time, they would take regular vital signs, blood pressure, pulse, weight, and then we added the waist circumference to abide by the new guidelines. And then IT worked with me to embed alerts into the EMR that reminded prescribers to add the laboratory testing so that we had all the components to properly screen for metabolic syndrome within this process. And lastly, if there was any abnormalities found, we would follow up with a referral to the prevention clinic that's within the clinic or the patient's primary care provider if they had one and if that's what they chose to do. The data selection preparation started after an internal review board approval from Maryville University. The university approved the project that was deemed exempt from a full IRB review. Ramsey County Mental Health Clinic didn't have an IRB, but however, administrative approval at the site was obtained to conduct the project. The data was collected after the retrospective chart review of the patient medical records was gathered, and there was no human subjects used in this practice change project. The guidelines recommendations were focused on trends identified in the literature review and supported by evidence-based practices for screening for metabolic syndrome. Practice recommendations based on literature is to identify individuals with metabolic syndrome through screening, then if symptoms are present or identifiers are present, referring them to the prevention clinic or primary care for follow-up and treatment. Themes identified in the literature review included keywords like metabolic syndrome, which is described as disease, hypertension, obesity, insulin resistance, and dyslipidemia. Metabolic screening, that's defined as the main components for screening for METs or metabolic syndrome, are measuring waist circumference, screening lipid levels, fasting blood sugar levels, measuring blood pressure, measuring weight, and reviewing their medications on the profile. Practice alerts are defined as implemented into the electronic health record, and that can change prescribers' behaviors and alert them to needed tasks that need to be completed. And then psychiatric prescribers are the practice guidelines provided evidence-based recommendations for assessing and treatment psychiatric disorders to assess in clinical decision-making by presenting systematic development patient care strategies in a standardized format. And then best practice guidelines that were used for this practice change were focused on themes that were identified. Again, the value of routine screening for metabolic syndrome and referrals to the prevention clinic or primary care. The practice alert was embedded in the medication profile of the EMR, and the specific laboratory tests for fasting lipids and hemoglobin A1Cs were notified for the prescriber to implement. The adult treatment panel guidelines established the screening included using Adult Treatment Panel 3 guidelines that were established by the National Cholesterol Education Program to identify those at risk for metabolic syndrome. Referrals to the prevention clinic, primary care to have any disorders associated with metabolic syndrome treated, such as high cholesterol, diabetes, or obesity. And then increased screening led to early detection and diagnosis and treatment. This project improved patient care by implementing changes to ensure the safe delivery of care. Efficient processes were made, and it improved the patient outcomes. The goals are goals that are considered gold standard for implementing a DMP project and practice change. This project improved patient care by implementing these changes to improve the safe delivery of care, efficient processes, and improve patient outcomes. There are both pharmacological and non-pharmacological guidelines and recommendations to treat metabolic syndrome. Some are heart-healthy food choices, to aim for a healthy weight, regular exercise, managing stress, quit smoking and finding quit smoking programs for individuals, having a good quality of sleep. Again, early detection is key, so screening is critical for metabolic syndrome detection. And then medications for diabetes, hyperlipidemia, and hypertension, like insulin, metformin for hyperlipidemia, different statins, and hypertension medications that are usually implemented to help control high blood pressure. The data inclusion criteria includes a chart review of 300 electronic medical records. The patient age was 18 years of older, and those prescribed with a atypical antipsychotic medication and was seen at the clinic during the time frame. The exclusion criteria were anyone under 18, anyone not prescribed an atypical antipsychotic, or those that were seen in the clinic outside of the range of this project. The instrument used again was the adult screening guidelines. We also embedded electronic medical alerts for prescribers to enter orders, and any abnormalities detected were referred to the prevention clinic or primary care for follow-up care. So the results part of this project is the most critical as it summarizes the data and helped to prove the PICO question. The metabolic screening data is listed on these tables, and the referrals to the prevention clinic or primary care will be on the next table shown. So the metabolic screening data using the Pearson-Chai test provided a value of Z of 16.9775 and a p-value of 0 and a confidence level of 95%, which indicates the pre and post intervention group comparison showed statistical significance. Post groups of the metabolic syndrome screened patient was statistically higher at 0.98 than the pre-group of patients not screened at 0. The hypothesis was rejected. The confidence interval suggests the actual change in the ratio from pre to post intervention. Since 0 is not included in the interval, we have significant evidence to show a change in one direction. The p-value less than 0.0001 is less than the significance level of 0.05. There is sufficient information to suggest an increase in the ratio from pre to post intervention. The post-group screen patients was statistically higher at 0.98 than the pre-group of patients screened at 0. The achieved power of the study is 1, which is considered high in strength. It showed a change in the interval from the pre-intervention to the post-intervention. There was significant evidence that showed a change in one direction. The data that the EMR or electronic medical records with positive screenings in the post-intervention group surpassed the electronic medical records in the pre-intervention group. The post-intervention group was significantly higher, which showed that the implementation of the screening for metabolic syndrome was successful. So the table shows the results for the referral to the prevention clinic. So this table shows how many patients were referred for follow-up care after being screened for metabolic syndrome. Patients that had referrals to the prevention clinic or primary care after being screened had a confidence rate of 95%. The results for the referrals to the prevention clinic or primary care are labeled throughout the table. The chi-square test provided a value of the pre and post group comparisons that showed the statistical significance of Z equals 15.2494 and the p-value of 0, and again, the confidence of 95%. The confidence interval suggests the actual change in the ratio from the pre to the post interventions. Since 0 is not included in the interval, we have a significant amount of evidence to show a change in one direction. The p-value less than 0.0001 is less than the significance level of 0.05. There is sufficient information to suggest an increase in the ratio from the pre to the post intervention. The project goal was to reach 100% proportion of compliance. The number of patients with referrals to the prevention clinic or primary care increased over the specified time, reflecting this statistical significance. Patients with EMR documentation or of the patients referred to the prevention or primary care after screening, the intervention was implemented, and the information suggests that the achieved power of the study was 0.05, and that's sufficient information that suggests that the utilization ratios of 0.87333333 increase the difference between the pre and the post-intervention groups referred to the prevention or primary care clinics. The sample size of the study is 300 EMRs, which is higher than the minimal amount that was required. The pre-intervention data collection from the EMR included N at 150 and N at 19, which meant out of 150 charts in the pre-intervention, there were 19 charts that were identified as being referred. In the post-intervention, 150 out of 150 charts showed that patients were referred to the prevention clinic for follow-up care and/or primary care after being screened for metabolic syndrome. Resulting of the proportion of 0, and in this post-intervention period, again, it included N of 150 with N of 150, resulting in a proportion of 1. And again, the average proportion is 0.05. The retrospective chart review design was ideal for evaluating the effectiveness of the practice change and provided strength to the findings. The project's design had adequate time constraints, which provided a substantial time to collect data, implement the practice change, and analyze the data. The project change guidelines and interventions are provided on the National Cholesterol Education Program website, with printable education materials given to staff during trainings held in the mandatory monthly meetings that we had. Online teachings and printable handouts provided time for staff to ask questions and review materials during and after the meeting. Lastly, the rigorous data collection methods increase the validity and reliability of the results and decrease bias. Some of the limitations and challenges of this practice change was there was high staff turnover. With that being said, we had to make sure that new staff had training within their orientation process. So having to go back over with supervisors to make sure the information was given and that they understood the information was challenging. So ensuring that training was there for all new staff and that they understood all the components and the DMP practice was challenging, but we managed to get everybody trained and it did not impact the results of the study. The ATP 3 guidelines help standardize the care at the mental health clinic, and all the patients that were screened for metabolic abnormalities help to provide a baseline to obtain the evidence-based research analysis. The project has relevant implications for Ramsey County Mental Health Clinic. It emphasized the importance of implementing evidence-based practice standards. Doctoral leaders use evidence-based scientific backed data to make safe clinical decisions and create high-quality practice enhancements and improvements. Additionally, the practice change enhanced the need for further research on association of screening for metabolic syndrome in the mental health or primary care setting. Practice and future research, early diagnosis, and treatment are critical. Community outreach can also be used to help professional organizations to inform the public and prescribers about the adverse effects of metabolic syndrome. Advocacy and quality and safety are recognized and eliminate barriers to screening and treatment for metabolic syndrome. We can also reduce the medical complication and prevention, increase knowledge of the continued advocacy for the need of this population served at the clinic. Metabolic syndrome is a serious health problem, especially for individuals served at Ramsey County Mental Health Clinic. Prescribers that diagnose and refer for ongoing treatment often have better patient outcomes. Findings of this practice change project was that implementing metabolic syndrome screening is essential for the health of individuals that we serve, especially individuals prescribed atypical antipsychotic medications. Early detection improves health outcomes. There were opportunities identified during this project. Some included the fact that 98% of patients that were screened for metabolic syndrome were referred to the prevention or primary care. And at the post-intervention period, 100% of patients were referred to the prevention clinic or primary care. Other clinics can benefit for screening for metabolic syndrome. There's often a lot of discussion of whose responsibility it is. Primary care feels its mental health responsibility as they're prescribing medications, and some mental health prescribers believe that it's primary care's responsibility. At the end, I feel it's all of our responsibility to screen for metabolic syndrome to help improve the patient outcomes and quality of care that they receive. And here are some references from the literature review that helped back the information in this practice change project. Thank you for watching, and reach out if you have any questions.